Hi everybody. So today I'll be speaking on the evidence-based management of refractory ascites. Let us come to the pathogenesis first. Pathogenesis of ascites. In patients with cirrhosis, there is a portal or the sinusoidal hypertension, which leads to the splanchnic or the systemic vasodilatation, leading to the decreased effective arterial blood volume, which causes the activation of the vasoconstrictor and the antinatriotic factors, which leads to the sodium and water retention, leading to ascites and hyponatremia. It also causes the increased cardiac output, high output heart failure, and then causes the decreased renal blood flow, leading to hepatorenal syndrome. We can intervene at different levels. Either we can do the sodium restriction, or the use of diuretics, or the LVP, or we can use tapes, or we can send these patients for the transplant, and other therapies as the vasoconstrictors may also be used. This is an overview of the treatment of ascites. The first line is usually the cessation of alcohol if these patients are having alcohol as etiology. The sodium restriction and the diet education is the most important. The dual diuretic use, although the standard of choice is the spironolactone, but for the rapid control of ascites, we use the combination of two, that is the spironolactone and furosemide with a single daily dose, and discontinue if you are already giving NSAIDs. Evaluate these patients for the liver transplant. Second line drugs, discontinue beta blockers, ACE inhibitors, and then if these patients are having a low MAP, then you can consider adding midodrine. The therapeutic paracentesis is very useful in these patients. And then again, you evaluate actively these patients for the liver transplant. You can take help of the tips also. This is the standard treatment of the ascites, cirrhotic ascites. It all depends on the cause. If there is a low SAG ascites, it will not respond to the salt restriction and the diuretics, except some patients with nephrotic syndrome. High SAG ascites, if there is an alcohol intake history, you have to stop it. And then if these patients are having HBV related or HCV related or AIH related cirrhosis, in that case, you have to treat the etiology. Identify the precipitating factors. The most common precipitating cause is the dietary indiscretion or the diuretic non-compliance. GI bleed sometimes may be responsible for this, or in these patients, there may be hepatocellular carcinoma with or without portal vein thrombosis. And many times these patients may be using NSAIDs, so you have to stop this. Sodium restriction is the mainstay of treatment, and sodium intake of 2 grams or 5.2 grams of salt per day, that is 88 millimoles per day, is allowed. And low salt diet alone may eliminate ascites in about 10% patients. The diuretic therapy is very important in these patients, and this is required in about 90% of patients. And the preferred regimen, as I told you, this is the combination of the spironolactone and the loop diuretic. And the advantages of the combination are that the greater and the faster effect on the urinary sodium excretion, acting at different tubular sites, less frequent development of hyperkalemia, and loop diuretic counteracts the potassium sparing diuretic of the anti-aldosterone drug. Then adverse effects are seen in about 20 to 40%. Spironolactone, the furosemide, is given in the dose ratio of 100 to 40 once in the morning, and then you can increase it to 200 to 80, 300 to 120, and finally 400 to 160. If these patients develop any painful gynecomastia, you can substitute it with the amiloride 10 mg per day in these patients to avoid the gynecomastia. The importance of the urinary sodium excretion, usually in these patients, the the diuretics are effective when you are having a sodium excretion of more than 78 millimoles per day. And the completeness of the collection can be calculated based on the creatinine excretion of more than 15 milligram per kg of per day in the men and more than 10 mg per kg per day in women. But many times it becomes difficult, so we can take help of the spot urinary sodium and potassium ratio. If it is more than 1, that indicates a 24-hour urinary sodium excretion of more than 78 millimoles. A negative sodium balance with weight loss of 0.5 kg per day and more in patients, the peripheral edema indicates a good response. And if there is no response, then increase diuretics after 3 days in these patients. Now coming to refractory ascites, this can be a diuretic resistant ascites or diuretic intractable ascites. The diuretic resistant ascites, if it is uncontrolled with salt restricted diet of less than 90 millimoles per day, with a 400 mg of aldactone plus 160 mg of furosemide, and diuretic intractable ascites if the complications prevent the use of adequate doses of diuretics. These are the problems with the refractory ascites. Before we call it the refractory ascites, the treatment duration, the patients must be on the intensive diuretic therapy, that is spironolactone 400 mg and is furosemide 160 mg per day for at least 1 week, and on a salt restricted diet of less than 90 millimoles per day. And when do we call the lack of response? If the mean weight loss of less than 0.8 kg over 4 days and urinary sodium output is less than the sodium intake, then we call it a lack of response. Early ascites recurrence is called when there is a reappearance of grade 2 or 3 ascites within 4 weeks of initial mobilization. Diuretic induced complications can be defined as diuretic induced hepatic encephalopathy, the development of encephalopathy in the absence of any other precipitating factor. The diuretic induced renal impairment is an increase of serum creatinine by more than 100% to a value more than 2 milligram per dl in patients with ascites responding to treatment. Diuretic induced hyponatremia is defined as a decrease of serum sodium by more than 10 millimoles per liter to a serum sodium of less than 125 millimole per liter. Diuretic induced hypo or the hyperkalemia is defined as a change in the serum potassium to less than 3 millimole per liter or more than 6 millimole per liter despite appropriate measures. The refractory ascites occurs in about 5 to 10% patients with the ascites, and once these patients develop ascites, the probability of survival goes drastically down. These are the methods, the options of controlling the treating patients with the refractory ascites. If these patients are taking beta blockers, you have to stop it. And if the MAP is low, you can use midodrine, you can do a serial therapeutic paracentesis, you can use tapes, and if nothing works, you can send these patients for the liver transplant. The large volume paracentesis is very, very effective, and this is the most commonly used method of controlling refractory ascites. But the problem with this is the paracentesis induced circulatory dysfunction. And in this study of paracentesis versus the diuretics, the 72 cirrhotics with the 10 ascites were studied, in which the paracentesis shortened the duration of hospital stay. And how frequently we should go for the therapeutic tab? If there is no urinary sodium excretion, the paracentesis is required every 2 weeks. And how do we calculate this? If suppose you are taking out 10 liters of paracentesis fluid, and that will contain somewhere around, because the 130 is the sodium level in these patients with the ascitic fluid, so 10 into 130, that is equal to 1300 millimoles sodium. And patients consuming 88 millimoles sodium per day, that is 2 grams salt, excretes 10 millimoles per day of the non-urinary sodium, and then they retain 78 millimoles per day. Therefore, 10 liters of the paracentesis removes 17 days of retained sodium, that is 1300 divided by 78, this comes to around 2 weeks in patients with no urinary sodium excretion. And patients with some urinary sodium excretion should require paracentesis even less frequently. If not, then probably they are not complying with the diet. And as I told you earlier, the spot urinary sodium can help in these patients. Look at the sodium and potassium ratio. If it is more than 1, that indicates a 24-hour urinary sodium of more than 78 millimoles. PICD is a major problem in these patients. It occurs in about 75% patients. If we are not using any plasma volume expansion, then 40 to 50% if we are using dextran or the polyzoline. And even when we use the albumin in the doses of 8 grams of the ascitic fluid removed, this is seen in about 15% patients. So in PICD, there is an arterial vasodilatation which causes the decreased effective arterial blood volume, and this can be prevented by giving albumin 8 grams to the per liter of the fluid removed. And however, there is apprehension of transmission of diseases, and the albumin is costly. Hence, earlier, the vasoconstrictors were also tried to combat the vasodilatation in these patients. This is a landmark study done by Morrow, in which he compared the patients who were given the albumin and the other group, the terlipressin was used, and then he found that the terlipressin was as effective as albumin in preventing PICD. We also did a similar study way back in 2006, and in that we included 40 cirrhotic patients, the 10 ascites. They underwent the LVP, and then we compared the effect of terlipressin with the albumin, and this was also equally effective in preventing PICD. However, the terlipressin being costly that time, and we switched over to NORAD, and in that we compared the NORAD with the albumin for the prevention of PICD, and you can see that also worked, and the PICD was equally in the prevalence in patients, those who were receiving NORAD. But here, the NORAD again, we'll have to give it in the intravenous, and that is why I switched over to the midodrine. It's again another vasoconstrictor, and in this, the vasoconstrictor midodrine has been proven to be effective in showing the improvement in the systemic hemodynamics in non-azotemic cirrhotic patients with ascites in a very early study by Paolo Angeli, published in Hepatology in 1998. Another study in which they tried the midodrine, which showed the reversal of type 1 HRS with the administration of midodrine and octreotide and albumin, and that was also effective. And we did the study in which we used the midodrine and then compared it with the albumin for the prevention of PICD, and this was again very effective and prevented the development of PICD. This is another study in which they used the 24 patients and they compared the midodrine with the albumin. However, in this study, the midodrine was not as effective as albumin in preventing PICD. This is a meta-analysis in which Bernardi included all the studies published, 17 studies, and then including 1,225 total patients, and they compared the development of PICD and the mortality. The PICD was slightly more in the non-albumin group, hence they concluded that albumin is superior to the other vasoconstrictors in the prevention of PICD and mortality. These are some of the newer therapies in which we looked at the action of the terlipressin. This was very early study done by Craig, and then they evaluated the terlipressin and then looked at the functions, the hemodynamics, and then they found that even in those patients with the cirrhosis and ascites without any HRS, this improved the hemodynamics. In this study, the midodrine was used in non-azotemic patients with cirrhosis and ascites, and there was a significant improvement in systemic hemodynamics. In another study by Tandon et al., the midodrine, octreotide, and the albumin was used for 1 month in 10 patients with refractory ascites. There was a significant reduction in plasma renin with a better control of ascites, and there was a reversible deterioration in the MELD score. Here we use the midodrine for the control of the refractory or the recurrent ascites. In this, we use the 40 patients with a refractory or the recurrent ascites. The midodrine was given in the doses of 7.5 mg 3 times a day. And the primary endpoint was the control of ascites. Secondary endpoints were the frequency of worsening encephalopathy, liver and the renal function, and frequency of other complications of cirrhosis, for example, variceal hemorrhage or development of hepatic renal syndrome, and 3 months of midodrine therapy. And it caused the mean arterial pressure increase, the cardiac output decreased, systemic vascular resistance increased, and then the urine output and the urinary sodium also increased. PRA decreased in these patients and without any renal or the hepatic dysfunction. There was a better control of ascites and better survival when we looked at the survival at 1 year. This is another study in which they looked at the midodrine in 78 patients, the refractory or the recurrent ascites. In group A, 37 patients, and then in the SMT group, and group B was a 41 patients with a midodrine group, and there was a reduction in the body weight, increase in the mean arterial pressure, and 24-hour urinary volume. However, this is another study. This is US multicentric study, patients with a refractory ascites, multicentric study. Midodrine and the octreotide versus the albumin was used in this study. Midodrine was given in the doses of 10 mg 3 times a day and a monthly 20 mg IM long-acting octreotide. Median times to the recurrence of ascites was 10 days in the albumin group and 8 days in the vasoconstrictor group, and the difference was not significant. In the PCD, the development was seen in 18% in the albumin group, and in the vasoconstrictor group, it was seen in 25%. So the midodrine was not so effective in this group. We use the midodrine and the clonidine, the combination of the two, and this has been a study of 60 patients with the refractory or the recurrent ascites, 15 patients in each group. And then we use the midodrine alone, clonidine alone, then the combination of both, and then the standard medical therapy. And midodrine again was given in the doses of 7.5 mg 3 times a day, and clonidine in the dose of 0.1 mg 12 hourly. The midodrine, clonidine, and their combination plus the SMT improved the systemic hemodynamics without any renal or the hepatic dysfunction. Midodrine and the combination of midodrine and clonidine plus the SMT was superior to SMT alone for the control of ascites. Clonidine plus SMT, there was a trend towards the better control. However, there was no superiority of the combination over the midodrine alone. The new molecule, this is the V2 receptor antagonist. This also has been used in these patients with ascites. It acts on the distal tubule of the kidney to increase the solute-free water excretion. In a multicentric, double-blind, randomized controlled study of 110 cirrhotic patients with ascites, they compared the effect of cetabaptan with the placebo, and there was a significantly better control of ascites. However, in phase 3 randomized placebo-controlled study, there was no significant beneficial effect of cetabaptan in the control of ascites. There was an increased morbidity and mortality. However, the cause was unclear. This was another study of ours in which we used the combination of the midodrine and the tolvaptan, and then looked at the the control of ascites in these patients, the refractory or the recurrent ascites. Midodrine was used in the doses of 7.5 mg 3 times a day, and tolvaptan in the doses of 15 mg 12 hourly. The midodrine as well as the combination of midodrine and tolvaptan plus standard medical therapy was superior to SMT alone as well as tolvaptan in the control of ascites. The combination therapy was superior to midodrine in the control of ascites at 1 month. That is, the complete response was 0% versus the 46%, and there was a trend towards the better control of ascites at 3 months. The complete response was 39% versus 69%. Mortality and the frequency of complications were similar in all the groups except SMT, in which renal failure was observed in significantly higher number of patients. This is the study in which they used the long-term administration of the human albumin, which improved the survival in patients with cirrhosis and refractory ascites. You can see the cumulative incidence of the mortality, which was lesser in the albumin group. Again, they also looked at the probability of the free from the hospitalization, and that was also lesser in the albumin group. And then they also looked at the ascites, that was better control, and so the SBP, especially in those patients who received albumin. This is another study, the so-called ANSWER trial, in which they looked at the efficacy of long-term human albumin administration in patients with decompensated cirrhosis. And this was a multicentric randomized parallel open label trial in 33 Italian hospitals. 431 patients were randomly included, and in the human albumin group, 40 grams twice weekly for first 2 weeks, and then 40 grams weekly for up to 18 months was given. 38 out of 218 patients died in the SMT plus human albumin group, and 46 of 213 in the SMT group. And overall, 18-month survival was significantly higher in the SMT plus albumin group than in the SMT group. That is 77% versus 66%. And hyponatremia episodes were also decreased. Ascites, the cumulative incidence of first paracentesis in the refractory ascites also decreased in the albumin group. This is another study where they use the midodrine and the albumin. In this, 196 patients with decompensated cirrhosis and ascites awaiting the liver transplant were used. And this was a double-blind placebo-controlled trial in which they used the midodrine and the albumin in 99 patients in the doses of 15 to 30 mg per day. Albumin was given 40 gram 2 weekly for 1 year. This was a dose which was lesser than the ANSWER trial. And no significant difference in the development of complications or 1 year mortality. There are various problems in the interpretation of this study. Majority of the patients underwent the transplant, so that is why there was no significant difference. Tips can be used for the control of ascites. This is a sort of the Porta cable shunts. The better control of ascites. Disadvantages are high rate of stenosis, especially when we are using the uncovered stents. But nowadays nobody uses the uncovered stents. These are the covered stents which are used. And another problem is the high cost, and then encephalopathy, lack of availability in some centers, and technical difficulties. Although nowadays we don't find any technical difficulties if these patients are subjected for the liver transplant. These are this is a meta-analysis involving the various trials in which they use the TIPS versus the serial LVP. And see, in this meta-analysis of 5 studies, the recurrence of ascites after 3 and 12 months was lower with the TIPS, and frequency of hepatic encephalopathy was higher with the TIPS. Survival, there was no difference in 3 studies, and there was the trend towards the reduced mortality in patients treated with the TIPS in 1, increased transplant-free survival in the TIPS group in 1. In this study, they used 62 patients with a recurrent ascites. It was a multicentric study from France, and in which they used the covered tapes in 29 patients, or LVP and albumin in 33 patients. The survival without the liver transplant at 1 year was estimated, and it was 93% versus 52%, and this was significantly different. And the more important was the encephalopathy in these groups was similar in the tapes and the other group, 35% in each group at 1 year. So the encephalopathy was not higher in the tapes group. This is another mode of the controlling the refractory ascites. This is automated low flow ascites or the alpha pump. What they do in this is they connect a pump with the tubings, and then the ascites is drained into the urinary bladder from the peritoneal cavity, and this is automatic. And in this study of alpha pump, this was a pilot study in which they used the non-randomized trial to assess the safety and efficacy of the alpha pump for the treatment of refractory ascites. There were 40 patients at 9 centers. The pump was implanted for the automated removal of ascites from the peritoneal cavity into the bladder. The pump system removed 90% of the ascites and significantly reduced the median number of LVPs. The complications were high. The 40% of patients required paracentesis. This is another study in which they used the alpha pump and then compared it with the LVP, assessed the safety and efficacy of the alpha pump compared with the LVP. This was again a RCT in 7 centers with a 6 months patient observation. Primary outcome was the time to first LVP, and 60 patients were randomized and 58 were analyzed, 27 in the alpha pump group, 31 in the LVP group. And then there was a significant reduction in the LVP requirement for the alpha pump patients, and this was significantly different, improved the chronic liver disease questionnaire scores and nutrition in the alpha pump compared with the LVP, and adverse events were more in the alpha pump, that is 96.3% versus 77%, and this was not very significant, and the serious adverse events were slightly more, and there was no survival difference in the alpha pump group. So this is the approach to the management of refractory ascites. If there is a patient with the cirrhosis with ascites which is not responding to the usual measures, look at the dietary sodium, because this is the most common problem. These patients are not adhering to the low salt diet. And then if this patient is already having alcohol as etiology, you have to stop alcohol. If they are taking NSAIDs, stop that. And then if these patients are having B related or C related, then you have to treat the etiology. And then also look at the imaging. There may be a HCC or portal vein thrombosis, and that may be the reason of the refractory ascites. And if these patients are also receiving the beta blockers, then the cause may be the beta blockers of non-response of the usual therapies. And in that case, always never forget to do a diagnostic tap in these patients. Majority time, these patients will have a low MAP. When you do a diagnostic tap, there will be a SBP, and then when you do the renal functions, you will get the renal dysfunction. This is a classical in these patients, so never forget to do a diagnostic tap. And at the same time, many times we may get evidence of tuberculosis. So always send it for the ADA estimation. And then look at the 24 hours urinary sodium. And then if not possible, then you can do a spot sodium and potassium. And then if it is more than 1 ratio, then that indicates that there is a sufficient natriuresis. And then you can do a serial therapeutic paracentesis, and of course always with the albumin, the 8 grams of the per liter of the ascitic fluid removed. And if it is not getting controlled, then look at the MAP. If the MAP is low, in that case, especially if it is less than 82, that case, you start this patient on midodrine. And how to start? See, the 2.5 mg or 5 mg of tablet is available. Do not start with the 2.5 mg. And always try with the 5 mg. But you have to be very clear that there is no contraindication for the use of midodrine. And then start with the 5 mg 3 times a day. Look at the MAP. If there is already an increased MAP of more than 10 millimeter of mercury with this much of dose, continue that, you will see a difference in the urine output and the ascites gets controlled. And then subsequently, you can increase the dose of the midodrine many times. As the time passes, the dose may not be so effective. These patients may be requiring a higher dose, so you can increase it. And then if it is not getting controlled, then these patients may not be responding to the vasopressor therapy. And always use the diuretic along with the midodrine. And if these are not responding to midodrine, then these are the candidates in which you can give a trial of the tips. And especially if these are not child C and then there's no background history of the encephalopathy, then you can give a trial of tips. That also works very well. And if nothing is possible, then these patients require a liver transplantation. But if by some reason you cannot send them for the liver transplantation, then you can take help of the LVP and the long-term albumin administration in these patients. Thank you very much. The first question by Piyush is what is the current status of the Vartans in the treatment of cirrhotic ascites? This probably was posted before I explained the role of the Vartans, but let me again repeat it. The Vartans have been used earlier, but the problem is that there was a black box warning, and the warning was given based on the dose of the tolvaptan, which was a very high dose of 160, 90 to 160, and then this dose was given for a very long time, for years together. These were the cardiac patients, and in that some very minimal percentage developed the hepatic dysfunction in the form of the enzyme rise, and based on that they gave that black box warning. But I don't think it is right. After that, even after the black box warning, we did have the study based on the tolvaptan and the combination of the tolvaptan and midodrine, and in that we showed that tolvaptan is very effective. But the only problem is that whenever you are using tolvaptan, use tolvaptan especially if there is no renal dysfunction, and the tolvaptan should not be used if there is low MAP. Then the tolvaptan should not be used in a patient who is in encephalopathy. Do not use tolvaptan in a very high dose. Although we use in our trial the 15 mg twice a day, and this was for a month, but I feel you can use it even lower dose, that is 15 mg. But before that, you should rule out any SBP, renal dysfunction, SBP, encephalopathy. If it is there, a low MAP, don't use tolvaptan. And if you are using tolvaptan, I will say that you can use the midodrine for a few days, but after that you can add tolvaptan in these patients, and you'll get a very rapid response, and the correction of the sodium is very fast. This especially if you are contemplating a liver transplant in a very near future. In that case, for the patients with a hyponatremia, you can use tolvaptan and midodrine in these patients. So the second question by Dr. Piyush again, how do we treat chronic hyponatremia in cirrhosis? This is again partially covered here. The chronic hyponatremia, if it is less than 125, then only we need to treat it, otherwise not. And the only thing is that you have to be a little careful, because most of these patients, they are having hyponatremia. Somebody will say the sodium is low. We supplement it with the high sodium, and that is the worst part. Because the moment you start giving them sodium, there will be again more retention of the water, then more hyponatremia. So the cycle goes on. So you have to be very careful. Do not supplement it with the salt. Do not give hypertonic saline. If it is going less than 125, if it is more than 125, you may not. But only thing is that you can give, you try to find out whether there's SBP, whether we are using the very high dose of the diuretics. Then if it is diuretic induced hyponatremia, stop that for some time. And if this is SBP, correct that. And see, in these patients, if you give albumin, then these patients, the hyponatremia will improve. And if nothing works, even without giving albumin, then in these patients, you can restrict the water, the less than 1 liter, and then you can take help of the tolvaptan, provided there is no contraindication. The moment you put these patients on tolvaptan, and you can also take help of midodin, that also improves the sodium, and midodin, albumin, tolvaptan, but you have to be very careful in choosing the therapy, because there should not be any contraindication to that. Then there is another question from Dr. Amit Kumar. Kindly comment on the management of ascites in CLD with a CKD on dialysis. See, if the ascites in these patients, many times it may be CKD related. So if it is CKD related, the management is of that of CKD. If this is a patient with a cirrhosis, and in this there is an associated CKD, you can take help of the usual measures of the diuretics, albumin, therapeutic tap. Ultimately, these patients will require the dual transplant. And because you can pull it on for some time, but you cannot pull it for a longer time. This is another question. Is there any study on the use of midodin in patients with a CA-CLD before decompensation or at the onset of decompensation? See, onset of in these patients, if this is a ascites, and which is very easily manageable with the other measures, there is no point in trying midodin. The midodin, the role comes only when you have tried everything, the MAP is low, patient is not responding. In that situation only, you go for the use of midodin. Yeah. Then there is another question. In your clinical practice, how often have you used the spironolactone 400 mg and the furosemide 160 mg before labeling the patient as refractory ascites? How do we decide on increasing the dose of diuretics? This is a real problem. Hardly our patients reach such a high dose. And before that only they start developing the other side effects. Side effects in the form of the hyponatremia, hyperkalemia, renal dysfunction. So the refractory ascites we see, but the refractory ascites is not because of the higher dose, which has become ineffective, but this is because of the side effects which start appearing. Then there is a question from Mayur. Any diagnostic criteria for the PICD or any blood test you prefer? The PICD, the diagnosis is based on the measurement of the renin, and this is actually not practical. So, but not only the renin elevation, The problem comes with the AKI also. These patients will develop AKI and these patients will develop hyponatremia. So the moment these patients have the hyponatremia or AKI, it means this is PICD. Otherwise, the best way of the diagnosing PICD is the renin and aldosterone measurement. Then this is maximum dose of midodin. We start with the 5 mg and then we can go up to 12.5 mg 3 times a day. But I have never used the 12.5 mg. I have used 10 mg 3 times a day. But the most of the time, I start with the 5 mg, go to 7.5 mg, and then once the ascites starts improving, then after that, I go back to the 5 mg 3 times a day. You can use it for a longer time. Then is stopping of the beta blockers needed in patients with the normal MAP and refractory ascites, because recent literature suggests myriad of the good effects of beta blockers in cirrhotic patients. Yes, I know the various studies are available. The dust has not yet settled, but if you are confronted with a refractory ascites and we are not able to control it, give a try, stop beta blockers, and then you see the response. This is from Dr. Sarad. Looking at the cost of metodin, what should be the adequate dose on the basis of cost-benefit ratio in our setup of the good efficacy in the refractory cases or cases with the renal dysfunction? We do not use in these patients, we do not advocate the use of 2.5 mg of the metodin 3 times a day. Rather, we should start with the 5 mg 3 times a day. And then I know this is a costly drug, but there are many competitors in the market now. The Myelin has also come. Cipla is already selling it. So there may be some more. And I think in the coming 6 months or 1 year, the cost of the drug will go down. But we should be judicious in using, do not use metodin upfront, use it when you are confronted with the refractory ascites and especially the low MAP. This is question from Dr. Kartar Singh. Why not to use the amiloride in the beginning itself? See, we can use it, but the amiloride is a little costly, but the standard the diuretic is the spironolactone. The Dr. A.P. Jaina, sir, some of my HIV patients are taking the metodin for managing the ascites. Is there any precaution you are suggesting? Metodin, I don't think it reacts with there is an interaction of the HIV drugs, but I have not checked it. I will have to check it. This is again another question from Dr. Piyush. Cirrhotic patients with the diabetic nephropathy, how to diagnose AKI or HRS? See, cirrhotic patients with the diabetic nephropathy, this is a problem in these patients. These patients are also having the diabetic involvement of the kidneys. That will be the clear cut. The guideline is there. You can diagnose it. But if there is a recent worsening or because of any other reason, and probably this patient is also having the AKI, and we have to follow the standard criteria of the diagnosis of AKI in such a group. This is another question from Dr. Divya. Sir, I have a patient who has a bilirubin of 5 mg, an AST of 750, is having moderate ascites and sodium of 126. I started low dose diuretic, but the hyponatremia worsened. Can I use? No, do not use tolvaptan. Try to look at the cause. Probably this patient is also having SBP. If you have not done any ascitic tab, do it, or look for the infection somewhere else, because this looks like a patient like ACLF, and if he's alcoholic, then look for the infection somewhere. Then only once you control infection, after that only you can try various methods. But do not use tolvaptan in such a patient. Try other measures first. This is Raghav. How to manage patient of HRS with refractory ascites and encephalopathy. See, the refractory ascites and encephalopathy. In such a patient, this is the usual picture. Encephalopathy, you have to treat first, and after that, you have to take care of the refractory ascites. In such a situation, we try to find out the other causes. The SBP is the commonest one. There may be infection somewhere, MAP may be low, these patients may be receiving beta blockers, stop beta blockers, and then after that, you can put these patients on the diuretics or LVP and the use of albumin. And if nothing works, you can give a trial of the midodin, and if nothing works, then you send this patient for the transplant. And then could you enlighten on when to consider torsemide over the furosemide? This is these patients, they tolerate both very well, and only thing is that the torsemide is slightly more effective, and you can use either of the two, and there is no question of switching from one to the other. Then this is Praveen. Till what duration we should prefer midodin therapy, and when to stop? The midodin can be continued if this patient is responding to midodin, then you continue till the ascites disappear. And we have used it for 6 months, 1 year, 1.5 years, 2 years. Usually within 6 months, these patients respond, and then the ascites disappears. But if ascites is not disappearing, in that case, you can continue midodin. This is, do you add midodin after achieving maximum dosage with the Lasix and Electone? See, this is after achieving Lasix and Electone. See, these patients will usually develop renal dysfunction or hyponatremia. So once you have done that, you have to stop diuretics in that situation and then restart again. Start the diuretics again, look at the dose which is tolerable, and then look at the various other factors. If the MAP is low and then the SBP is not there in that case, and the renal dysfunction is not there, in that case you can use midodin. This is again Mukesh Kumar. This is what are consequences of stopping beta blockers for ascites. See, normally these patients, the beta blockers, if they are receiving, they are having viruses also. So you are giving it for the prophylaxis. If you have eradicated the viruses, then only there is a point in stopping beta blockers. If you have not eradicated viruses, there is no point in stopping beta blockers. Otherwise, these patients will have a varicose bleed. So be careful. Do the eradication of the viruses, and then after that, if you are finding that this is a refractory ascites, in that case, you stop beta blockers and start treating refractory ascites. Then Dr. Piyush again, is there any replacement for the albumin as it is costly? There is no replacement of albumin. This is costly, I know, but you have to use it. In a patient with AKI in refractory ascites, is there any tool to predict response to volume repletion with albumin? Or is there any tool to say that we have to go for the albumin with the terlipressin right away? If it is AKI, and then you go as per the guidelines of International Club of Ascites, establish the AKI Give albumin for 48 hours. If it is not improving, then you have to use the vasopressors, and the vasopressors are never given alone. They are given always with the albumin. IAC recommends the albumin of 6 to 8 grams of, this is ACAS from our place. IAC recommends the albumin at 6 to 8 grams per liter of the ascitic fluid removed for the PICD prevention. We do a 6-liter tap. Minimum required is 36 grams of albumin. However, in clinical practice, most use 20 grams only. Is there a case of change this dose requirement recommendation? I know this is a wrong practice. We should, if as per the 6 grams of the ascitic fluid removed, and if this is 40 grams, then you have to give 2 units of the albumin. So don't give 20 grams. Always there is a chance of the under treatment may result into PICD. How to improve? This is how to improve serum sodium in a cirrhotic patient with ascites, and very low sodium of less than 110, patient is asymptomatic. These patients, the chronic hyponatremia are usually asymptomatic, but it is unlikely that the patient is having 110 and this is totally asymptomatic. But this patient also requires treatment, and treatment in the form of the look at the infections and then look at the map. You are not giving beta blockers. In that case, give albumin, and then if it is not improving, then you can use the midodrine. And I don't think you should use the tolvaptan in such a patient, because especially when he is asymptomatic. And this is Rakesh Kumar. Can midodrine and the diuretics combine together in a specific situation after AKI recover? Combination of the beta blockers with the midodrine, is it rational? Yes, the first one, the midodrine and the diuretics combined together in the specific situation after the AKI. Yes, many times the AKI recovers and there is an acute precipitant, and once the AKI recovers, in that case, you can go on the usual lines of the management of the ascites. There is no question of managing AKI in such a patient because it has recovered fully. Once it has recovered, there is no question of using the midodrine for the AKI. So be careful, use the other therapy, and then if the ascites is there, you can use the diuretics and all, albumin, and then the various guidelines when to use the midodrine, as I discussed it, you go for that. Then you are saying the combination of the beta blockers with the midodrine. Yes, there is a rationale, theoretically yes, because the beta blockers will cause the low MAP and the midodrine is going to increase the MAP. Yes, in some patients, if you cannot stop the beta blockers because the viruses are there, in that situation, very difficult situation, you can use, under refractory ascites, you can use a combination of beta blockers and midodrine. This is again Mayur. What should be done next if ascites is not resolving even after TAFEs? Send this patient to the transplant. Then is there a safe cutoff for the serum albumin level in cirrhotics? What is the significance, and do we need to manage it actively? The significance, and do we need to manage it actively? See, what do you mean by safe cutoff for the serum albumin? Serum albumin is always low in these patients with the cirrhotic ascites. And see, as the albumin level goes down, all the complications increase. The infections are more, SBP is more, so you have to be careful. And then you keep giving the albumin, maybe weekly 40 grams, that is given by the answer trial. So you can keep giving the albumin. So another question from Dr. Kartar Singh, ACLF due to drugs causing refractory ascites, and then when to suspect stopping the drugs being given. for comorbidities like the diabetes and the hypertension. If the ACLF is due to drugs, first you have to stop the drugs, and then once the ACLF recovers, then you have to take care of the refractory ascites. In the meantime, if there is a tense ascites, you can take help of the large volume paracentesis. And can we use the carvedilol instead of the propranolol in refractory ascites? No. This is clear-cut no. In patients with refractory ascites, you should not use carvedilol because that causes the profound hypotension, because the combined effect of the alpha axon. Is metodin useful in HRS-AKI? There are studies because this has been used at length in US, because the Turley is not available there, and that is why they have used it, and it is useful when it is given in the metodin, albumin, and then the octreotide in patients with the HRS-AKI, but it is not very effective. The drug of choice is still the terlipressin and albumin. Again, Dr. Praveen, how much increase in the MAP we are targeting with the metodin therapy, and whether it is a factor that shows metodin is working. Yes, if you find that 5 mg TID you have given, and this drug is not causing even a slightest rise of the MAP, it means there is something wrong. Either the drug is spurious or there is some problem. So in that case, you have to be careful. Normally, if the MAP 5 mg of the metodin 3 times a day, if we give, there may be increase of 5, 7.5 or 10 millimeter of mercury rise in the MAP. If that is there, then it is good. How much of the fluid can be removed for LVP? Does the rate of fluid removal need to be monitored? If yes, how do we do it in the clinical practice? See, the only thing is you have to give the supplement the albumin in these patients after doing LVP. But if you are taking out 10 liter, 15 liter, then you imagine the amount of albumin you have to give, and these patients will not tolerate. So it is always better to take out maybe 5 liter or 7 liter. 10 liter you can go, but don't go beyond that. 10 liter means 60 grams, means 3 bottles. Okay, so it is always better that you, if you give it more than 3, then each bottle lasting for 2 hours or 3 hours, then how long it will take? See, it is not practical. And these patients, if you give more and more of the albumin, these patients will go into left ventricular failure. And regarding the monitoring, there is no question of monitoring. You can take out as fast as possible because nothing happens. And only thing is that you have to supplement it with the albumin. What is your recommendation for the ascites causing distress and patient has hyponatremia? Should LVP be done in hyponatremia? Yes, you should do LVP. You have to weigh the balance, do LVP, and then give albumin, rule out SBP, and then take care of the hyponatremia. Rohit, how to manage systemic hypertension in patients with the HRS-AKI? Like we can't give the ACE or the ARB inhibitors as well as the beta blockers. Is the cardioselective beta blocker is safe in HRS-AKI? This is safe. There is no problem in that. Only thing is that if it is a patient with the cirrhosis, usually what happens in these patients, by the time they develop cirrhosis, although they were hypertensive initially, the requirement of the antihypertensives goes down, and then they are off the antihypertensive. So it is very, very rare to have a hypertension and cirrhosis. See, you have to find out there may be a nephropathy also. So there may be a CKD rather than the AKI and then the ascites. So you'll have to be very careful, rule out any CKD in such a patient. Akash again, can hypothetically a long-acting octreotide plus the midodrine be useful in these cases, especially as outpatient therapy? Outpatient therapy for the refractory ascites, yes, many people have tried it, and this can be used. But why do you want to use the long-acting octreotide? Are you talking of the AKI, or you are talking of refractory ascites? If you are talking of AKI, yes, of course, but give albumin also in these patients. But if you are talking of the refractory ascites, there's no point in giving the long-acting octreotide. You use the midodrine and the albumin that will do the job. Vinod Kumar, how often do you use the antifungal in refractory ascites with the sepsis? We do not use the antifungal in the refractory ascites with the sepsis unless we have proven that there is an infection and the infection is of fungal infection, and if in the last we are suspecting an infection and we have tried all antibiotics and the patient is in sepsis, in that case we can use antifungal therapy. We have seen some patients with the fungal SBP also. Rakesh Kumar, any role of bolus Turley or the mido before starting LVP? See, the point is that for the prevention of the PICD, there has been studies on the terlipressin or the midodrine, and this has been proven that these are the drugs which can prevent the development of PICD. But I will say that the interpretation was based on the smaller studies only. The Bernardis, the meta-analysis showed that these drugs are not so effective in controlling in preventing the PICD. Hence, I'll still go for albumin therapy only. Praveen again, sir, any drug-to-drug interactions has been seen with the midodrine, and any dose adjustment is required in renal impairment patient. There is no need of doing a dose adjustment, but only thing is that I do not use or advocate the use of midodrine for the AKI, because there are better drugs available. The terlipressin is a fantastic drug to be used in patients in the HRS. Then Rohit, please highlight the cardiac issues with the terlipressin. You have to be very careful if the ejection fraction is less, or any other abnormality. In that case, any arrhythmia is there, do not use terlipressin, or for that matter, midodrine also in these patients.
So thank you so much. There were plenty
there is
of
another question from Dr. Sahaj. Sir, could you please explain how giving sodium in cirrhotic hyponatremia may be harmful? Yes. See, I'll give you an example. There was a patient of the hyponatremia which was being treated outside, and what they were doing is they will just, because this was hyponatremia and they wanted to give a high salt, so they opened the B complex capsules and they filled it up with the salt, common salt, and they used to ask him to take these salt capsules. And the chronology was like this. The physician will do a therapeutic tap. Since the hyponatremia is there, they will again give these salt capsules, so-called, and then after another 3 or 4 days, again they will have to. So what happens, if you are giving a high salt diet, that is retained in the body, and then that will again retain the fluid. So the ascites worsens. So there is a more and more hyponatremia, and the sodium also is not passing in the urine. So there is a more hyponatremia, and then the ascites worsens, hyponatremia also worsens. Manoj Kumar, how long to continue midodrine? This question has already come. We can continue midodrine till the ascites last if you are finding a response. If there is no response, you have to look for the other reason why there is no response. This is a question from our faculty, Dr. Nipun. Sir, please tell the role of modest LVP in the presence of encephalopathy and ACLF. Yes, this is, I know there is a study from ILBS. They have tried to befool the system. System means the system of ACLF patients. They have tried to take out the lesser amount of the ascitic fluid and thinking that this will not cause the PICD. But if you do it repeatedly, these patients will definitely develop PICD. So I'll go to the chat questions now. And in the chat questions, the Arun, how to dose albumin in refractory ascites? The dose of albumin, I have already told, the 40 grams. If you are thinking of the dose for prevention of PICD, then of course this is the 6 grams of the per liter of the ascitic fluid removed. If you are thinking of the albumin given for a longer time, as it was given in the answer trial, so give 40 grams. And then again, this is, sir, could you, Rathi, sir, could you please explain how giving sodium in cirrhotic, this I have already taken. Harish Kumar, in CLD patients, we get huge scrotal swelling. What is the management strategy? This is nothing different. This is only the management of ascites. The ascites gets accumulated there, so you have to manage that. Dr. Babulal Meena, sir, what would be the dose of albumin? I have already replied. The dose of albumin for the PICD and for the ascites control, the long term. Is there another question from Sankar Baral? Which patients of refractory ascites you don't recommend to go for TIPS? If there is a patient with the frequent encephalopathy, child C, and then these patients, there is no point in, and there is a evidence of infection anywhere, no point in asking for the TIPS. Then Harish Kumar, this is how does SAG ratio help in the management of, SAG is very useful. See, if this is high SAG, this is the cirrhotic ascites, portal hypertension, and this is going to respond to the diuretics and the salt restriction. Then the Jafar Ali, if we say ascites in CLD is a complication of portal hypertension, then we don't give beta blockers, rather they are contraindicated. No, these are not contraindicated. See, the beta blockers are indicated in patients with the portal hypertension, but this is a special situation, the refractory ascites. Some of these patients may not respond to the usual therapy of ascites, and in that case, you have to stop the beta blockers for the control of ascites. The Pradeep Kumar Shetty, one of our resident, how much diuretics can be given with the midodrine? You can give the usual dose of diuretics, and you have to weigh the checks and balances. If somebody is using midodrine and the diuretic minimal dose only, and if the output is 1.5 or 2 liters or 2.5 liter, there is no point in increasing diuretic, because that is going to unnecessarily increase the side effects. Dr. Sidhu, role of octotide and LAR, sir, what's your experience? Yes, I already told that the long-acting octotide can be used, but the better drug is for the management of AKI is the terlipressin. In CLD with the ascites, what is the guidance for the IV fluids? In CLD with the IV fluids, there should not be any sodium containing fluid. It is better because these patients are already having ascites and a lot of fluid is there. So what you have to do is you give albumin rather than the fluids. Saurabh Misra, our resident, RA is an indicator of the liver transplant. So sir, use midodrine as a bridging for LT, and all these patients should be referred for PT transplantation prior to starting midodrine. Yes, you can use midodrine, and all these patients are candidates for the transplant. Sanjay Kumar, is alpha pump available in India? It is not available in India. Moreover, it is very costly and severe side effects are quite frequent. No point in trying to find out the alpha pump. Then, what is the role of cardiac assessment before starting therapy? Yeah, we should be very careful. And this is from Dr. Amandeep, our resident. We'll have to rule out any cardiac dysfunction. If if there is a cardiac dysfunction, we should not use midodrine or terlipressin in these patients. Abhiman, how to interpret the answer trial results? They had included patients who were already on higher diuretic doses. So whether to give weekly albumin to all the decompensated CLD patients, irrespective of diuretic doses. It is there are few studies, other studies also apart from the answer trial, and in that they have given long-term albumin, and the control of ascites is better, the complications are lesser. So it is, although it requires further trials to prove it 100%. What is the initial dose and dose pattern of the midodrine? And I have already told, and this is in the algorithm also. See, start with the 5 mg, rule out all other contraindications, start 5 mg 3 times a day, and then slowly look at the map. If there is already an increased map of 5 to 10 millimeters of mercury, you don't have to increase it. Look at the urine output also. If there is enough urine output, you just continue this. If not, then you have to increase it to 7.5 mg 3 times a day. So Q&A, I missed early 15 minutes of lecture. Any optimum mild score to go for the tips? And the refractory ascites, if tips in refractory ascites with the sarcopenia. There is a tips in refractory ascites with the sarcopenia. See, you can go ahead with the tips, but sarcopenia may improve in these patients because the ascites is a major problem, and these patients, the nutrition suffers because of the ascites. Amitesh Kumar, if a patient of refractory ascites develop renal dysfunction, can be used midodrine with the somatostatin or the terlipressin. In patients with the renal dysfunction, the midodrine is not very effective. You can use the combination of the octreotide and midodrine and albumin, which is the drug which is used in US very frequently. Dr. Sunny, this is how early we can send the patient for tips. If this is a refractory ascites and nothing worked, you can send this patient for tips. This is Jatin. Will a recorded session be available? I was unable to join the webinar. Sir, suggest that the literature to study for refractory ascites management. ASLD guidelines have, or ESL guidelines have beautifully given, and the management of refractory ascites. Presentation next time, again, we'll come with something new, and we'll answer most of the questions. Okay.
Thank you, sir. Have a great day. Bye, sir.
Okay, bye.